Good afternoon, everyone. My name is Akifumi Kishi. I'm a postdoctoral fellow working at NYU School of Medicine. First of all, I'd like to thank the committee for inviting me as a speaker today. It's a pleasure to be here, and I appreciate this opportunity to participate in this meeting on diagnostic criteria for ME/CFS. I've been working on the analysis of sleep data in patients with ME/CFS, working with Dr. Benjamin Nelson since I was a PhD student. So today, I'd like to present our findings so far, as well as a brief overview of existing literatures on sleep disturbances in ME/CFS. ME/CFS is a disabling condition characterized by severe fatigue, which substantially reduces normal activity. In addition to severe fatigue, one of the symptoms used for diagnosing ME/CFS is unrefreshing sleep. This sleep-related problem is the most common complaint among patients with ME/CFS. Also, characteristics in ME/CFS is that even minimum exertion produces a worsening of symptoms in ME/CFS. Research has been done to examine objective sleep disturbances in ME/CFS because the identification of objective sleep problems in ME/CFS may help understanding of pathophysiology of ME/CFS and also may help developing treatment of ME/CFS. Sleep problems, including unrefreshing sleep, are commonly seen in patients with primary sleep disorders, which include obstructive sleep apnea, periodic movement disorder, narcolepsy, etc. Previous studies have shown that approximately 45 to 60% of the patients with ME/CFS presented with primary sleep disorder. Also, according to larger population-based studies, approximately 20% of the patients in the studies were found to have primary sleep disorder, while approximately 10% of asymptomatic healthy controls presented with primary sleep disorders. Thus, it appears that primary sleep disorders are moderately prevalent in ME/CFS patients. There is an argument in that whether primary sleep disorders should be considered as a diagnostic exclusion or a comorbid condition with ME/CFS. Since the Fukuda criteria, sleep disorders have been considered as diagnostic exclusion of ME/CFS. In fact, there is overwhelming evidence of the distinction between ME/CFS and primary sleep disorders. Also, ME/CFS patients with a comorbid sleep disorders were found to have greater functional impairment. These are a piece of data which highlights the importance of considering a potential sleep disorder as a cause of the symptoms of ME/CFS. On the other hand, supporting the idea that primary sleep disorder should be considered as a comorbid condition with ME/CFS, it has been reported that the symptoms of ME/CFS did not differ between ME/CFS with and without sleep disorders. Also, another data have shown that CPAP, continuous positive airway pressure therapy in ME/CFS patients with comorbid OSA did not result in any substantial improvement in the subjective symptoms. Now moving on to objective investigation of sleep using polysomnography. Polysomnography, PSG, is a standard clinical tool to objectively assess sleep physiology. EEG, electroencephalography, EOG, electrooculography, and EMG, electromyography. These three are critical in sleep stage scoring. And airflow and oximetry are required to diagnose OSA. Sleep stages are scored based on R and K, Rechtschaffen and chaos criteria, and recent modification by AASM, American Academy of Sleep Medicine. Sleep stages are divided into wake, non-REM, and REM sleep, and non-REM sleep is further divided into stage 1, 2, 3, and 4 based on R and K. And now in AASM rule, as shown in red, stage 1 is called N1, stage 2 is called N2, and the stage 3 and 4 are combined into stage N3. Each sleep stage has a characteristic feature such that wake and N1 is characterized by fast frequency and low amplitude EEG. N1 is characterized by fast frequency, N2 is characterized by characteristic waveform EEG, such as sleep spindles and K complexes. N3 is characterized by so-called slow wave or delta sleep, which has slow frequency and high amplitude EEG. And REM sleep is characterized by rapid eye movement and muscle atonia, while EEG during REM sleep is similar to that of wake and N1. This figure is a traditional hypnogram showing a time course of sleep stages over the course of the night. Conventionally, sleep is assessed by calculating sleep variables, which include total sleep time, which is time spent in non-REM or REM sleep, sleep efficiency, which is a percentage of TST to the time spent in bed, sleep latency, which is a latency to sleep onset from lights out time, REM sleep latency, which is a time from a sleep onset to the first epoch of REM sleep. Wake time after sleep onset, WASO, is a time spent in wakefulness after sleep onset to the lights on time. And total time or a percentage of time spent in each sleep stage. Here, I'm showing a summary of the literatures looking at sleep variables in ME/CFS patients. This table only includes studies done for second night of PSG, which eliminates possible first night effect on the results. Also, in these studies, medication was off at least 2 weeks prior to the experiment, or in one study, medications are statistically controlled. The result is, as you can see, mostly there is no difference in sleep variables between ME/CFS and healthy controls. There are 2 studies which found decreased sleep efficiency and increased sleep latency in ME/CFS, both of which indicate disrupted sleep in ME/CFS. The first 2 columns, highlighted by the red box, these studies employ the design of the study with monozygotic twin pairs discordant for ME/CFS. Twin study would be the most powerful and robust design of the study. And in those studies, again, mostly, there was no difference in sleep variables. The only difference seen was in increased percentage of REM sleep in ME/CFS, but the difference itself was actually small. So overall, for sleep variables, it appears that there is no specific or consistent objective sleep characteristics found in ME/CFS. And it has been a dilemma that there is no clear objective evidence of sleep disruptions in ME/CFS, although the patients present with significant daytime symptoms. Given this situation, we have been working on the analysis focusing on the dynamic aspects of sleep. The left panel shown here is a traditional hypnogram. And in reality, the analysis of traditional sleep variables has been limited to simple static descriptive statistics such as total sleep time, sleep efficiency, and total duration of each sleep stage. Whereas traditionally it is taught that sleep stages follow a very stylized or periodic pattern like this traditional hypnogram, in fact, actual hypnogram looks like a right. The actual hypnogram displays rather complicated or complex time series with dynamic transitions between sleep stages. These dynamics of sleep stage transitions are composed of sequential transitions between sleep stages and the duration of the bouts of each sleep stage. These two features, transitions and durations, are considered sufficient in describing the path to specific episodes that might lead to poor sleep quality. So the analysis of sleep stage dynamics should account for the transitions and duration. To characterize and quantify the transition between sleep stages and the duration of each sleep stage, we calculated transition probability between sleep stages and duration distributions or cumulative duration distributions for each sleep stage. Transition probability was calculated by dividing the number of the transition from a specific stage to one of the other stages by the total number of the transitions from the specific stage to another stage. For example, when calculating probability of transition from N2 to N3, the number of transitions from N2 to N3 are divided by the total number of the transitions from N2 to wake, N2 to N1, N2 to N3, and N2 to REM. As for the duration distributions of each sleep stage, we calculated cumulative duration distribution, which is equivalent to the survival curve of the bout durations of each sleep stage. By using this transition analysis, we studied 26 healthy controls, 14 CFS patients without fibromyalgia, CFS alone, and 12 CFS patients with fibromyalgia, CFS plus FM. None of the subjects had clinically evident sleep disorders and none were on medications. Fibromyalgia, FM, frequently occurs in conjunction with CFS and FM often have similar symptoms, including sleep-related problems. Despite their similarities, difference has been reported between CFS and FM. So in this study, we hypothesized that the analysis of sleep stage dynamics could reveal objective differences in sleep in CFS with or without fibromyalgia. The results can be summarized in this simplified diagram. In this transition diagram, arrows represent patterns of transitions between sleep stages, and the thickness of the arrows corresponds to transition probability. We found that, as indicated by red arrow, the probability of transitions from REM to wake was significantly greater in CFS alone than in healthy controls. On the other hand, we found that, as indicated in green arrows, the probability of transitions from wake, N1, and REM to N2, and transition probabilities from N3 to wake and N3 to N1 were significantly greater in CFS plus FM than in healthy controls. In addition, the probability of transition from wake to N2 and N3 to N1 were significantly greater in CFS plus FM than in CFS alone. So it seems that REM is disrupted in CFS alone, while slow wave sleep was disrupted in CFS plus FM, but CFS plus FM having more transitions to N2, deeper sleep stages, which might reflect greater sleep pressure. As for cumulative duration distributions, we found that duration distributions for N2 sleep were significantly different between CFS plus FM and the other two groups of healthy controls and CFS alone. So specifically, CFS plus FM had shorter N2 bout durations. This finding was consistent with a previous study by Burns and colleagues. They showed shorter N2 bout durations in FM patients compared to healthy controls. So it appears that shorter N2 bout duration could be specific to FM, not to CFS. Now I'm summarizing the results and going through the interpretation of the findings. First, CFS alone had greater probability of transitions from REM to wake. This could be a specific sleep problem in CFS alone and could be interpreted as lower sleep pressure during REM sleep in CFS alone. Supporting this interpretation is a report that the sleep latency was not shortened in CFS patients even after the sleep deprivation. In contrast, CFS plus FM had greater probabilities of transition from waking, N1, and REM to N2, suggesting the increased sleep pressure in CFS plus FM. Also, CFS plus FM had greater probability of transitions from N3 to N1 and N3 to awake, suggesting this may be the specific sleep problems in CFS plus FM. This interpretation is consistent with a previous study showing that disruptions of deep sleep result in the symptoms resembling fibromyalgia. We also found that shorter N2 bout durations may be specific to FM, not to CFS. This is consistent with previous studies showing decreased sleep spindle density and power in FM patients. Finally, the implication of this finding is that the fact that the coexistence of FM alters dynamic sleep stage transitions of CFS patients suggests CFS and FM are different pathophysiologic underpinnings associated with different aspects of sleep regulation. In the next study, we studied the effects of exercise on dynamic aspects of sleep in healthy controls and patients with ME/CFS. We studied exercise effect on sleep because the post-exertion malaise is a disabling and characteristic feature of ME/CFS. So we expected to find some relationship between sleep disturbance and symptom worsening in CFS patients. The subjects were 16 healthy controls and 17 CFS patients. Again, none of the subjects had clinically evident sleep disorders and none were on medications. After having the adaptation PSG, the subjects underwent baseline PSG. At the next visit, in the afternoon, the subjects performed maximum exercise test, which is an acute exercise by electronically braked cycloergometer. And subjects were asked to exercise as long as they can, only once. And the acceptance condition was, as shown here, heart rate greater than 80% of age predicted maximum heart rate, and or respiratory exchange ratio greater than 1.1. This was followed by post-exercise PSG. We also measured visual analog scale for subjective symptoms of fatigue, pain, sleepiness, feeling blue, and anxiety. Those are collected before and after each PSG. we hypothesized that the subjective symptoms in CFS patients might be correlated with specific sleep abnormality. This figure is showing that difference of sleep variables where the value on the baseline night was subtracted from that on the post-exercise night. So positive difference means greater value on the post-exercise night. Sleep variables are categorized in two ways. One is variables indicating better sleep, and the other is variables indicating worse sleep. For example, total sleep time and sleep efficiency are the variables which indicates better when they are greater. So the gray shaded area in this figure indicate better sleep after exercise. Similarly, for variables indicating worse sleep, such as WASO or N1, negative difference indicate better effect of exercise on sleep. In this figure, blue bar represents healthy controls and red bar represents CFS patients. What we found was that exercise significantly reduced sleep latency in healthy controls and also significantly reduced N1 sleep in CFS patients. These are thought to be overall very modest effects of exercise on sleep. The right figure shows difference of subjective symptoms, fatigue, pain, sleepiness, blue, and anxiety measured by visual analog scale. These are the difference of subjective symptoms in the morning, where the values on the baseline night were subtracted from those on the post-exercise night. So a positive value indicates increased symptoms after exercise. In this case, patients with CFS reported increased fatigue in the morning after exercise compared to the baseline morning. So taken together, this data is showing that exercise improved sleep modestly, but patients reported increased fatigue. When looking at the effects of exercise on sleep stage transitions, we found that exercise promoted transitions from N1 to N2 in healthy controls, and exercise promoted transitions from N2 to N3 in CFS patients. This indicates that transition analysis may be more sensitive to capture alternations of sleep than simply using traditional sleep variables. Also, patients with CFS had greater probability of transition from REM to wake compared to healthy controls. This was seen as a main effect of condition, so it's interpreted as CFS having greater probability of transition from REM to wake at baseline night, and then they continue to have REM sleep disruption on the post-exercise night. So after exercise, CFS reported increased fatigue and continued to have REM sleep disruption. Therefore, we further examined the relationship between subjective symptoms and REM to wake transitions, which could be considered as a specific sleep disruption in CFS patients. Here, we show correlations between transition probability from REM to wake and change of the subjective symptoms, fatigue, and sleepiness overnight. We found that probability of transition from REM to wake was significantly positively correlated to symptom worsening overnight, controlling for condition. for patients with CFS. There is one extreme data point in each panel, which had 100% transition probability from REM to wake, but we confirmed that the significant correlation remained for fatigue and sleepiness, even after excluding the extreme data point. So in this study, exercise improved sleep in CFS, but CFS continued to have REM sleep disruptions. The degree of REM sleep disruptions was significantly correlated with the worsening of subjective symptoms overnight. In summary, it appears that traditional sleep variables do not differ between controls and CFS, ME-CFS. Newer approaches in analyzing sleep, focusing on dynamics of sleep stage transitions, are emerging and could capture sleep disruptions in ME-CFS. But this would need more research in the field and also need to be replicated. For this point, PSG would be still useful tool to objectively investigate sleep problems in ME-CFS. PSG is required to diagnose primary sleep disorders, which is prevalent in ME-CFS. Lastly, I would like to thank all study participants, many collaborators of the studies, and funding which enables the studies presented today. Thank you.
Thank you so much for your presentation, Dr. Kishi. And Dr. Diamond, Betty has a question.